Okay, Allie, I got a problem.
Oh, no. Tell me.
One of our guests has the same last name as me.
Oh, that's going to be weird.
Yeah. She's very pretty.
I agree. I'm looking at her.
Yeah.
I kind of feel.
Yep. I happen to be married to her. Okay.
Oh,
We have two really.
There's another one too. He's also attractive. He's not my husband, but I feel bad. I want to make sure he knows he's equal.
Oh, we're talking about the other psychiatrist?
Mm-hmm.
Well, he's fine looking. Indeed he is. But we have two really, really solid psychiatrists. And all right, I'm gonna read their kind of formal bio type thing so we can get the formality out of the way.
Yep, we're gonna be serious.
And then we're gonna have some really interesting stuff to talk about. So let's talk about Dr. Becker. Dr. Jonathan Becker is a partner and medical director of the Neuroscience and TMS Treatment Center, the Brentwood location. He's a native Tennessean born in Memphis, right? He completed his undergraduate and master's degrees in developmental psychology at Tulane and completed his medical school at Des Moines University. He completed his psychiatry residency program at Vanderbilt University and served as faculty member there for 7 years before transitioning to private practice. While at Vanderbilt, Dr. Becker served as medical director for the neuromodulation service from 2017 to 2020. Very smart dude. And
Google neuromodulation. After this.
Yeah, very, very smart. Very, very fun to talk to. Very, I think both these guys make psychiatry very approachable. Like they're brilliant, but at the same time, they're very accessible. I think that makes them great clinicians. So Dr. Michelle Cochran is the founding partner and chief medical officer. Huh? What was that?
Rawr.
Okay.
She's your wife.
That was the sound effect. Dr. Michelle Cochran is the founding partner and chief medical officer of the Neuroscience and TMS Treatment Center and has been living and working in Nashville for 25 years. She has been offering TMS services since 2011 and lectures and consults nationally and internationally about TMS, which is true. They're going to Australia to train, into London, and quite a few others, and of course, tons of places in the States. And so they really are leaders in the community in that. She's board certified and distinguished fellow of the American Psychiatric Association and the Clinical TMS Society. And there's tons more about both of them, but we'll put those links in the website and go from there. You got your questions lined up?
Of course.
Your behavioral health, psychiatric type questions.
Yep.
Lined up. All right.
I've only got 4, so.
All right. I'm looking forward to it. Let's hang tight. We'll be right back.
From our studios in Nashville, Tennessee, this is Healing Centers, a podcast where we talk to experts and leaders in wellness, mental health, physiology, fitness, nutrition, and any other topic that helps us get through the day with purpose and through our life with long-term success and health. Follow us on Facebook and Instagram, and please give us 5 stars wherever you listen to your podcasts. Visit our website at www.healingcenters.co to share feedback, suggest future episode topics, and find out more about the people on our podcast.
I like that music.
I feel like she actually brought up a pretty valid point, even though it was a mistake.
What happened?
That's not my voice. That's M's voice.
Yes. Em was my original podcast partner, and after a couple of children,
bigger than I did, so I came on in.
You know what I'm saying?
I was second pick, but
you know what I'm saying? No. It's all good.
I'm proud to be second pick.
It is all good. You're number one. You're number
but yes,
one.
that is another amazing person who knows the Cochrans.
So we've got all right. So I think an interesting place to start is just to hear from you guys about your clinic and your partnership, just from you, because we can look at the website, we can read stuff, and we can hear things, but just kind of hear from you. And I think that's a fun way to listen to it. But Dr. Becker, let me start with you. In your words, what is the Neuroscience and TMS Treatment Center? You know, what do you do? Who do you help? You know, what is it?
Well, it's a very broad question.
It is.
I mean, I would say at its essence, the goal of our center is to provide comprehensive psychiatric care to patients, providing evidence-based medicine, and really trying to stay on the cutting edge of what's new to work aggressively to get patients better.
That was impressive.
That was it. Yeah.
Mm-hmm.
That was good.
I feel like what you've said that maybe stood out the most to me is cutting edge, because I think one of the things that I refer to you all the most for, not that this is what you all do, is treatment resistant diagnoses. And so I think there's so many psychiatrists out there, and I want to get into this a little bit later about the difference between you guys and them. But I feel like one of the big differences is like, you guys don't stop. Like, I feel like people who come to you all are like, I've tried 33 medicines, and you're like, oh my gosh, that's just the beginning.
Right.
Like, I got you. We're going to do this. And I think that's so rare in your field to have psychiatrists that, I think it shows how much you care, is how I interpret it, because you can make just as much money by just continuing to write the scripts.
Right.
But you're like really invested in, hey, there's this new thing that's out there for how you felt for 40 years. I think it really might be the thing that makes you not feel like this for the next 30.
Yeah. I mean, I think that's a good point. There's lots of options beyond medications that a lot of people are not aware of or never offered. And then the other thing is, there's really no point to try 33 medicines over 10 years. I mean, we know, statistically, after you've done 2 medicines, your chance of responding to a 3rd, 4th, 5th, et cetera, it drops really dramatically.
Really? I didn't know that.
And so, while there's still lots of other medication options after you've only done 2, you do then want to start making yourself aware of the other options. And that's where the neuromodulation comes in, things like TMS, would really kind of jump up there as something that is on the table for you at that point.
Can I ask a question that's not on our email?
You ask whatever you want to ask.
Why don't more psychiatrists do that then?
That's a good question.
That seems so like obvious to me.
So,
yeah, no,
do you care?
No, go on.
All right. So I think what's going to happen. So TMS and other sorts of, we're saying neuromodulation, but what we're referring to is something that affects the brain very much like meds, because meds are neuromodulation. It's just chemical neuromodulation. What we're talking about is something that's more of an electrical or a magnetic than electrical neuromodulation. It changes the brain. And these treatments have been around since like 2006, particularly with like VNS, right? So you got FDA cleared really early, and ECT's been around 40-something years, 50-something years. Right?
1939 was the first
lot
ECT
of years,
treatment.
Right? So we've had these other treatments, other ways to affect the brain, and you'd think that they would have caught on like wildfire. But psychiatrists are a conservative bunch, and a patient bunch. Maybe a little too patient. I think new docs that are coming out now that are really excited about these treatments are able to see, and I think TMS, it's been FDA cleared since 2008. It became very easy to offer that because you can offer it in your office. You don't have to go to the hospital, right?
The stigma around that too is so different.
Right. So I think what's going to happen is eventually I don't know why every psychiatrist won't have a TMS device in their office, because you should.
And have we introduced what TMS is yet?
Yeah.
Just for those.
So
It's
glad you said
TMS is transcranial magnetic stimulation. And do y'all want to give kind of a quick primer on kind of that?
You're up, Dr. Becker.
Just so we know what that is.
Yeah, so it's transcranial magnetic stimulation. But what it actually does is, for people that love physics out there, which I didn't understand the physics of it until I started doing it, but it basically uses a magnet and then a coil. And with that, you can generate a focalized electrical field that stimulates a small part of your brain that's underactive in depression to make it more normally active. So it's called magnetic, but it's really using the physics of the magnet to use electricity to directly stimulate the brain. Because really the brain is the most electrical organ in the body, the heart probably being the second. So it makes sense that you could use electricity to affect the activity of the brain circuits. And we do this in all kinds, pacemakers for cardiac arrhythmias. They do it for the deep brain stimulation for Parkinson's disease. This is done in many areas of medicine to use electricity as a modality of treatment.
And it's like day in, day out. Like you can go kind of like you run your errands. Like I'm going to go get my TMS treatment. I'm going to go to Kroger and get my bananas. I'm going to go
You
to
can.
Home Depot and get my wood.
It takes anywhere from about 3.5 minutes to up to half an hour, maybe a little bit longer for some patients. It's a determination the physician makes with the patient to determine which particular protocol to use, and then you have to actually see how the patient's brain's going to respond to the device. So you have to do some things.
I guess like only people who are millionaires could probably afford this. I mean, it sounds so expensive.
It's not expensive, and it's covered by insurance. It's been covered in the Middle Tennessee area since about 2013, I think, for a lot of insurance plans. And so some people, I'm surprised all the time. I don't usually look at patients' proposals that are sent from our billing department to them, but every now and then I'll look, and some patients pay nothing. Some patients pay a very minimal fee, like $5 per session. Some patients, they've met their deductible, so it costs them, $500 for the entire course. And then some patients can pay, some people can pay up to $7,000 if their insurance isn't covering it.
Some people's medicine costs $700 a month.
Exactly. So, and a lot less expensive than a lot of other treatments that are out there.
Yeah.
So.
Yeah, and I think too important to note, this is not something you do every day indefinitely.
Right.
This
is.
is.
Yeah, tell me about that.
It's a standard kind of 6-week course, 5 days a week for 6 weeks, and then there's a taper phase of a few more weeks with decreasing number of treatments. But this is not something that you have to do forever or indefinitely. Yeah.
But what I know about you guys is, even if that doesn't work, y'all are like, we're still going to the finish line.
Yeah, we have other options.
So you have other options.
Yeah.
Are y'all kind of unusual in that? I mean, I feel like you're unusual in the fact that you do TMS in general.
I think there are a few other practices.
Have another step after that is pretty unusual.
I think there are a few other practices that offer things other than TMS, but I don't think there's anybody that puts the whole package together where we have, we have lots of patients in our office that don't need TMS, right? They come in, they've never been on a medicine before, so we'll try some medicine, try some psychotherapy with them, and they can get well, and we're happy for them. And, some of those patients we refer back to their primary care doctor to get the medicines ongoing, and other people stay with us, want our expertise in that respect. And then those folks who need TMS, we'll prescribe that, but we offer Spravato treatments, which is esketamine. We can talk about that more, but we also offer VNS through a study trial. We'll refer people to outpatient ECT. So there's lots of options for lots of people. So we don't give up, like you said. So in fact, that's the first thing I say in every consult is, I'm going to talk to you about what options we have available. And the biggest thing I want you to hear is there's lots of hope to get you well, right? Yeah. We have lots of things. Depression is not metastatic stage 4 cancer. It is like cancer, and then it's recurrent. It can come back, and it can sneak up on you. So we have to be very aware of what's going on with you after we get you well. We want to keep you in remission, but we don't want to give up ever. Why would you want to give up on that? People can experience
you're an anomaly in that way, though.
I know, it's sad.
Yeah. That is something that's frustrating to me when I get somebody that's been sick for 10 years, and you look at the list of meds, and they've been on a list of 10, 15 different meds, but all really from like the same 3 classes. And so they've, even though it's 15 different names, they've really only done about 3 different things to try to treat their depression. And that's frustrating to me, that it went on that long before somebody said, let's do something different. Because the reality is, there's even lots of other medication classes that are hardly ever used that are really good, but just a lot of people don't prescribe them.
Interesting.
So this
I would like to go get my doctorate in neuroscience after this.
Is that what you're going to do?
Yeah. I'm like, what are the other classes?
Is that what you're going to do?
I would like to do that.
So we kind of backed into depression. we dove a little bit into quickly TMS and things like that. We kind of backed into a little bit depression, but is that the main thing you guys are treating? Sounds like that's definitely the priority with TMS.
Not the main thing. I mean, we treat, anything and everything psychiatrically related.
Yeah.
It's just probably the most common,
most
prominent psychiatric illness out there. But, we see a lot of anxiety, OCD, PTSD, some psychotic disorders, it ranges the spectrum.
And so if you're talking about therapy and medicine management for any one of these given states, what would be the, for the interventional treatments like, I guess, TMS, right? And esketamine, what would be the issues that people would want to solve?
Are you looking at like the indications for these?
I mean, why would you think about using TMS,
So TMS is indicated by the FDA, or it's cleared by the FDA for three things. So the Food and Drug Administration said and looked at the research and said, certainly you can use this for major depressive disorder when one drug has failed. And Dr. Becker kind of alluded to it a minute ago, but there is tons of evidence when one med fails. Most insurance companies make you fail 2. Some insurance companies, which will just remain unsaid since we're in Tennessee, but one insurance company makes you fail 4, which absolutely makes no sense. There is no evidence to limit it, right? But so most patients can get it covered by their insurance after they failed 2. There's economic data showing that you should do TMS before you even do meds, because the outcomes are so good with TMS that it makes no sense to do a med. Most medicines, their durability, I think the best med is Trintellix right now, has like 60% of people still well at a year.
That's it.
That's pitiful, right? So with TMS, even after you've failed meds and you do it, your durability, you've got like almost 70% of people staying well at a year, which is like some of the best durability you can get with anything that we use in psychiatry. But so TMS is also indicated, I think I said it, so it's depression, OCD, and smoking cessation. Now, if somebody were to ask me to treat a patient for OCD with TMS, I would want to make sure that they had failed all the typical medicines and ERP therapy for that, exposure response prevention therapy.
Before
I did that. Yeah, it just doesn't make any sense. I don't want to advocate. Most insurance companies aren't paying for it for OCD yet because it just got indicated a couple of years ago. And the ethical thing to do is to make sure you failed other meds and psychotherapy that's appropriate. You could do it if they've failed all those things, and it's highly effective. I've treated a couple of patients now with it, and it works. I can't tell you how durable it is yet because we just don't have data.
Or the
just
OCD.
using TMS for OCD. So kind of interesting. A lot of the devices now have that indication. You also have an indication to help with smoking cessation. And honestly, I'm not sure I would do that with a patient yet, but there is an FDA cleared indication. So
How's that a different part of your brain than like any kind of addiction? Maybe I shouldn't ask this question.
No, it's a good question, right? So
where like you would just do it for all of that.
There's a specific type of coil that actually has the indication, and it actually gets deep enough to hit the part of the brain that's called the insula. And so the insula is a circuit. So TMS and most neuromodulation or electrical neuromodulation works by working on the circuit of the brain. Right. So I usually like to draw this out, and it's going to be really hard in a podcast, but I'll try my best to describe it. So the front part of the brain that is in a human that controls our executive functioning, the stuff that makes us think, it's the part of the brain that can let us think logically, right? That's the prefrontal cortex. And that part of the brain is, so to speak, offline for depression. It's not working very well. And that's actually where you place the coil, is in the prefrontal cortex. But the prefrontal cortex is connected to what we call the emotional part of the brain. Allie, a lot of therapists call this the lizard brain, or the emotional part of the brain that controls all the reactivity, the high emotion, the high depression, the high alertness. And actually that part of the brain is called the subgenual area of the anterior cingulate. Big old fancy word, right?
You got that right, Chuck?
Yeah, I wrote it down, right?
Yeah.
SGACC, right? So that part of the brain, the emotional brain, is hot, bothered, excessively active in depressive disorders, and actually in PTSD and other kinds of really significant anxiety disorders. And so that circuit where the prefrontal cortex is low in activity and the subgenual area, subgenual ACC is high in activity, that circuit is what's busted, so to speak, in depression. When you put the coil over the prefrontal cortex and you get that area activated or more online by kind of training it daily to have some electrical activity, you actually reduce the activity in the subgenual area of the anterior cingulate. And so that really highly emotional part of the brain that would typically interpret everything emotionally slows down and quietens. And the other part gets really activated and more logical, so that you can see things, oh, that's not something that should bug me so much, and I can divert my attention to something else. And it's what gets someone out of the depressive episode. And so that's what you're kind of aiming to do with TMS. Or it's curious. It happens with TMS. You can reverse those processes. But curiously, anything that works for depression, including psychotherapy, reverses those processes. So we know that's what's broken in depression. We know that whatever can swap it the other way will work.
This is kind of the tier of it that you need, maybe. Like some people who come in and psychotherapy reverses it, but if that doesn't, right, you don't feel like it's just not going to work.
Right. So maybe if that part is so broken that psychotherapy can't undo it, then maybe a med will work. Or if med doesn't work, then we do something more directly electrical or indirectly electrical like TMS, or we do something bigger like ECT, or we do something like S-ketamine, which is basically a version of ketamine.
That's what I want to ask next.
Okay.
So.
Me too, man.
We all know. I went to Auburn. I had fun.
Oh, is that right?
Yeah. But that's not what we're talking about. But people think that that's what we're talking about because... What
are you saying? It sounds like you're alluding to something.
Like cutting edge to me.
So Auburn's a big vet school, too, so they probably had a bunch of ketamine running around.
Oh, did they?
I bet they...
So that's not... I don't know about the ketamine, but I know about some other things, like maybe some vegetables or something.
Yeah.
But I feel like... TMS sounds cutting edge to me, but I'm sitting here with you all going, I guess that's not that cutting edge because it's been around for so long. I just think psychiatrists aren't as brave as you all are and out there. But I feel like there's other things, like patients come in all the time, Chuck, and say, like, whenever I smoke weed, I feel so much better. I'm like, oh, geez. I don't know what to tell you about that. It's like, what's the future? Like, you guys are already kind of on the cutting edge of future. But I feel like we're really in an evolution kind of when it comes to psychiatry in a way that we haven't been in a while, maybe, of all these other things. They're coming to the forefront. I think there are a lot of psychiatrists, which I want to touch on this later because you said are conservative. I actually think they overprescribe. A lot of times that's kind of, or maybe that's the cultural assumption is that they're overprescribing, but they're not doing anything like TMS or these other things that you've said.
Yeah, I think it goes back to their overprescribing the same 3 or 4 classes of medications.
Right, because they're conservative.
So then people lose their trust in them, but they still feel so sick.
Yeah, and it can be very defeating because you say, well, I've done 10 meds, but what you don't realize is you've done 10 meds that are all really variations of the same.
Yeah, so when you're talking about the classes, you're really talking about fundamentally a very similar, I guess, molecule, if you will.
Right.
And so they're doing kind of the same thing.
Yeah, I mean, it's like a Coke and Pepsi, sort of thing.
Right,
So
or
it's
Lexapro, Celexa, and Zoloft.
Right.
They've been given all 3, and you're like, why?
are we not? I don't understand.
And they'll say, I failed 3 meds. It's like, well, yes, you have, but you've really only failed 1 class of.
Interesting.
And there's plenty others.
So, so people come to me all the time, and they're like, I think I'll feel better once Tennessee passes a law that I can smoke or something. I'm like, I don't understand this.
Yeah, so we don't have good, there's not good evidence that marijuana improves anxiety or depression long term. Huh. There's great evidence that, glass of bourbon or some wine will reduce anxiety short term, like in the few hours after you use it. But long term, it actually, all those things will promote more anxiety the next day.
It's like when you wake up. It's like when you wake up at 2 a.m. and you're like, right.
And the catch is that for everybody? No. Some people can drink alcohol and they're fine the next day. Other people can smoke marijuana and they're fine the next day. I'm not an anti-weed, anti-cannabis kind of doc. But the chronic use of it, the daily use of it, really you start kind of wondering, okay, you're trying to medicate, and particularly when people come to see me, and they're telling me how depressed and how anxious they are, and they're daily using, I kind of scratch my head and look at them very empathically. I mean, I'm very sympathetic to the situation. I'm like, you're trying to use something to help, right? You're self-medicating, but it's not working. I have better things. So
that's
I get
not
it,
the
and that's
future
helpful.
of it,
I don't think that's the future with that.
What is that?
Yeah. I mean,
interesting.
to back up, I'll just say I've not been impressed with any of the research on cannabis for like long-term treatment of depression or anxiety. But also, like Dr. Cochran, I'm not going to beat people over the head and tell them not to do it if, but I think the thing that's not realized about cannabis is it's not a totally harmless drug. It is cannabis use is a big trigger for psychotic illnesses. And so that's something that people don't realize is that, cannabis can induce psychotic episodes that can really change the entire course of someone's life.
Wow.
So.
Yeah. Right, there's a high association with schizophrenia and new onset cases, and that's what's scary, right?
Yeah.
So what is the future of psychiatric treatment then?
So I'm not going to say exactly what it is because I don't know, because I don't have a crystal ball. Although one of my patients bought me one years ago, and so there's one. I can't say anywhere I don't have a functional crystal ball. How's that?
Yeah.
So I have some suspicion that there's some good emerging data. There's good emerging data with accelerated TMS. There's also some good emerging data with psychedelics. And so the first psychedelic we actually have that's FDA cleared or FDA approved is Spravato. That's what esketamine is. It's interesting to me that Janssen really has not marketed it as the psychedelic that it is, because it blocks NMDA receptors. And so NMDA receptors are, most people probably know, if folks who are listening have used any kind of substances, ecstasy is a big NMDA receptor blocker. And so esketamine does that. And so people get the same kind of effects short term. But what we see that is so different than drugs of abuse is that esketamine and ketamine actually promote neuronal growth. So people develop new neuronal pathways, which is why I think people become so much more flexible when they're using the substance and after getting treated with the substance. And also what we know is there are tons of elevations of their levels of neurochemicals, right? We know that the inflammation in the brain reduces. We know that, unfortunately, though, even as good of a treatment is, it's not something that creates a profound amount of durability. So we have, fortunately, Janssen has worked on some data. I think that they just produced in some scientific posters that shows like kind of 4-year data on this treatment. But patients actually still have to maintain monthly treatments in order to maintain stability. So they can't just use this and get better. But there are some
less than like taking a med every day.
Yes, that is, and I mean, but it's kind of cumbersome. It's 2.5 hour process of taking a med. It's not, you don't just get to.
But wanting to live.
Yes.
Totally worth that once a month.
Yeah, I would agree with you. So particularly that it works for suicidality. That's an amazing thing. So, but I think there are some psychedelics emerging that look like they might have, that you might be able to use them less. right? So you might be able to get more profound response. I don't know about the maintenance, though.
Yeah, well, and something I want to highlight with the S-ketamine and ketamine is just that you know, I see a lot of people out there that are using ketamine that they're, you know, and a cash pay IV practice, or even there's some services now where you can just, you know, order it online.
Yeah, I see that a lot.
But the big thing that is not told to these patients is that within a few weeks, 1 to 4 weeks, your depression will come back. And so this is something that is, you know, going to be an ongoing treatment for you to really control your depression. And when I look at these advertisements online, it'll say things like, you know, $2,000 for, you know, six treatments and, you know, cure your, well, I don't know that they say cure, but
They
they'll
do.
say,
There is
some
one
of
that
them-
says
I'm
that
sure
locally, and
I'm
it's so
sure it
sad.
kind of does cure it for
Right.
4 weeks.
For 4 weeks. Well,
And-
that's not a cure, though. That's,
Right.
It's going to treat it for
Right.
4 weeks.
And
right?
so what people don't realize they're getting into is, you know, now they're basically going to pay, you know, that price indefinitely. And eventually I see a lot of patients that end up coming to us because they've just run out of money. You know, they've been doing that for
So let's
2 years.
let's touch on that a little bit, because you guys dove deep, which is awesome, into the clinical piece of it. But the difference in ketamine and S-ketamine and Janssen, where's all this lay in, and how does that help someone pay or not pay?
Yeah, well, so the big benefit there is that the Spravato, the S-ketamine, is covered by insurance.
Okay, so hold on, I'm going to talk slow. So S-ketamine is ketamine or a type of ketamine?
Ketamine, so anytime you have a chemical, so here's some organic chemistry from you. You have two sides of basically the molecule, the S side and the R side.
Okay.
So the S side is basically the left half of the molecule. They've isolated that. The reason they've done that is because you can absorb that through your nose, intranasally.
So instead of infusions,
which is R-ketamine and S-ketamine, it's both halves of the molecule.
Okay.
They've isolated out the S-ketamine, which can be more readily absorbed.
They call
you
that an
have to
isomer.
learn this in neuroscience if you
No,
get your
you learn this
doctorate.
in
and
your
You learn it
first
in
year medical school.
This is first year medical
so
school
I
stuff.
won't apply for that
Yeah.
then. Never
and so
mind.
that's a nasal spray.
Yes,
But the big difference money wise is insurance.
is the insurance pays for it.
Insurance can pay for that
Which-
versus an infusion style private pay $2,000 every 4 weeks type situation.
Right. And that's why, when we were talking about, starting a ketamine service, that's the big reason we chose to do the Spravato S-ketamine instead of the IV clinics. To be honest, it's more profitable to do the IV clinics.
Yeah.
Sounds like it, right?
A lot more profitable. But the reality is that's not what's best for the patient, because that's not affordable or maintainable. Is an option to treat the depression.
Yeah, and to be honest, we actually entertained the IV ketamine. We talked about this for a long time about eventually trying to create a center where we had an IV ketamine center. And I don't know if you saw it, Dr. Becker, but Yale published their data a couple weeks ago. I actually did a blog post on this a couple weeks ago when they posted it. But Yale has a ketamine clinic, and they were offering half of their patients S-ketamine and half of them IV ketamine, and took a retrospective look at all the data from the medical center and said, oh, look at this. Our S-ketamine people who are getting it intranasally and the insurance companies are paying for it, it works just as good as the IV. All the docs thought the IV was working better. But the data did not show that. The data showed that the intranasal spray was working just as well. In fact, locally, there was this big push by a company showing that IV works better. There's absolutely no evidence of that. So the intranasal works just as well. Patients get better, and there's probably maybe long-term a better outcome because patients know what to expect. They know they're going to be on it maintenance-wise, and so there's good data there. So
yeah. And as my public service announcement too, going back to the online thing, you will see people that will do oral ketamine. Mm-hmm. They will compound their own nasal ketamine, not S-ketamine, but the two halves of the molecule. Mm-hmm. I've even seen where they'll ship ketamine suppositories to your house.
Oh.
There is no evidence about the bioavailability and the effectiveness of oral ketamine, compounded nasal ketamine, and ketamine suppositories.
I just learned so much.
Hang tight.
Yeah.
I'm going to take a quick break.
Yeah, I feel over.
And yeah, we dug deep quick. Let me do a quick commercial, and then we'll come back and maybe pull back just for a second. Here we go.
This podcast is brought to you in part by the Neuroscience and TMS Treatment Center, where we are excited to provide evidence-based mental health services by board-certified clinicians. We spend the time and provide the attention you need to get you or your loved ones well. We can help find your path to wellness with treatments including medication, psychotherapy, TMS, and more. Visit us at www.hopeforyourbrain.com to learn more or to schedule an appointment. Make sure you let us know you found us on this podcast.
Okay.
So you
All
know
right.
I'm kind of a pendulum swinger.
Wait, yeah. Let me reel you guys in.
Here it goes.
Y'all dug deep quick, and that's awesome. I love it. But I still had a few other questions.
Oh.
On the, because you do seem to offer, and I do want to get back into the clinical side of things, but just as a practice, you guys do seem to offer sort of a different mode of behavioral health care than what a lot of other folks are doing or other clinics. And so I kind of want to learn just a little bit more about that. And just being in the healthcare business, I know there's a lot of groups that will join, doctors will, or people will share a receptionist, but they're really their own independent practice, which is a great, way to run your business. But you guys are partners, right?
Yes.
And so why does one choose to partner versus let's pitch in some money and share a receptionist type thing? What do you gain from that, if you will?
That's a good question, Chuck. Wouldn't have thought of that.
What am I, chopped liver?
I mean, I'm impressed. That's
Okay,
all I gotta
okay.
say.
All
All
right.
right.
So personally, I was kind of the original founder, and I think the reason for a partnership is to give a physician kind of ownership and oversight of the practice, right? So we're physician-led partnership, right? Physician-oriented. So it's all the decisions are kind of made at a clinical level, right? So we're going to make the decisions to maintain evidence-based care, right? So that's my thought about it. So
You got 2 cents?
Yeah, well, I guess I think the other thing too is a partnership. You have the physician oversight and leadership, but there's also accountability to make sure that we're all doing the same standard of care. Because in the model you're talking about, we're in the same building, we're going to share some overhead expenses, but they may have very different styles of practice.
Right.
And so, you may not get the same type of care from one doctor that's right next door to the other doctor, even though they're in the same building. And what we're trying to do is make sure that it's a standard of care across the practice. No matter who you see, you're going to get the same options, same treatments, and same potential for outcome.
Yeah. And curiously, is it more attractive for a talented younger doctor to want to join a partnership?
Sure.
Or are they like, oh, I think I'll share pencil and office supplies expenses over here,
I would hope so. I want to back up for a second, though,
Yeah.
and say something maybe a little differently than Dr. Becker said it that I thought of while you were talking. So I feel like it's a little bit of iron sharpening iron, right? So when you have two people who have some knowledge and you can both kind of keep each other kind of, so to speak, accountable. We do this a lot with the psychiatric nurse practitioners that we supervise, but also to each other of like, hey, I saw this. What can we do about this? What can we do a little differently? If you have a bad outcome, you had a good outcome, you have something that you want to talk through and kind of brainstorm about this. And we do this with everybody in the practice. I did this earlier tonight with one of the therapists in the practice and talk through it with a patient or about a patient and just kind of spend some time both helping each other get better and to help the patient get better. So
I feel like it's so funny. Maybe we need to change the title of our podcast.
What we haven't officially titled it yet. It's just it's a working title.
Since you and I are the only ones who listen to it,
we can call it whatever we want.
Because I feel like this theme comes up every freaking time. It's like we're better in community, Chuck.
Better in community. Okay.
We are better in community.
Yep.
It's so funny. It's like this really smart profession that they have, and then me, and it's like we all still do better in community.
So how big is the partnership? Because it's not just you two, right? I mean, you two are the doctor partners, but there's
that would stress me
quite
out if it was just the two of them.
That's quite other. You have a bigger team of, like you said, psychiatric nurse practitioners and therapists that all work in concert. Is that right?
yes.
Yes. How many?
How many right now? I have to count. So we're adding 3 new docs this summer.
Okay.
So 2 will be in East Nashville. 1 will be in a Brentwood location on Franklin Pike. Dr. Becker's on Maryland Way.
Right?
So
we'll put the
Maryland
data
Farms.
in the links.
Yeah.
We'll get everybody
I'm
access.
in the Nashville
There's
office.
a lot of need for this service.
Yes, we could be 15 more.
Now, are you
docs
talking
and probably
about
not
psychiatric
get
care
what we need.
service or this particular model that they're developing?
This particular.
So here's my argument is that
this is a unique.
there is such sort of a I think your husband and I were talking, but in some places there's just a desert of really proper behavioral health care.
There is.
And sadly, you can be okay and still make really good money because you're the only one there, or you don't have to take insurance, or and so some of this partnership model, is sort of self-inflicted. I really want to make myself better, even though financially maybe you don't have to, right?
Yeah, right, yeah.
But long term for patient care,
Really
you do have to.
controversially, I'd say that, you could be really bad and still really make money and be out on your own and be a silo.
In fact, you probably make more money doing that than
So
doing ketamine every other week, right?
Yeah.
What so when a patient is exploring, or maybe they're out of this market, what questions do they ask to find you or people of your caliber in their community versus someone who may or may not be a good fit for them? What's a good thing to ask or think through, if that makes sense? Or is it just reputation and referrals?
Answer this for them.
Yeah, I was going to say that's a hard question.
I can go
and maybe
there.
This is a little. I don't know what the word is.
You
like,
can look
I'm
at
being
you
honest.
can look at reviews, right? So I think the majority of people that come to see us get referrals from multiple locations.
Okay.
When I ask people, how'd you get to my office? They usually say, so my sister and my primary care doctor and my OBGYN and my therapist and my all suggested I come see you. Mm-hmm. Well, it's flattering to me to
So
hear
at a certain
that.
point in time, they're like, okay, I'll go.
So, but it does take people a long time to go and see somebody. We have some hoops to jump through to get in our office because, frankly, we want people who are invested to want to get better. But there's a lot of those people.
So you're saying
right?
some people are not invested in wanting to get better?
Ooh, I just stepped in a big pothole there.
I
But
actually
yeah,
think that's
but
true.
I think it is probably true.
I think there are a lot of parents that really want their kid to get better, but the kid isn't ready to get better.
And if they're not ready to get better?
Or if you're in the midst of that kind of, she described it so much more in the doctorate of neuroscience way. But I say it's like all your electrical wires are exposed and somebody poured a big bucket of water on it.
Mm-hmm.
I'm like, gosh, honey, if you're in that place, you don't need to make the decision.
Right.
But if you're in that place, like you don't really want to maybe get better. So this is what I think people should do.
Go.
I've never been this. It's me. I'm ready.
But
what was that? Like 6 years ago, I was in this practice and I was like, dang it, who's this Dr. Cochran person? Because everybody who went to her was like, I was on 17 medicines and now I'm on 3 and I don't think I need to see you anymore. I'm like, what the heck is she doing that everybody else isn't doing? And so I think it made a really big impression with me.
Okay.
But I think as I got to know her and then Dr. Becker, what they do different is, and I don't mean to be like too therapeutic, emotional about it, but they really listen. I think there are a lot of psychiatrists that are like sleeping a long time, don't want to work out, pick this up at Walgreens. And the person's out and they feel relieved because it was like quick. I'm like, no, you have so much here and all of it's valuable. Like not just the fact that you're sleeping 12 hours a day. Like
I'm sure there is a patient.
All of this is important.
There is a patient population that want convenience, want it quick, want more of their meds that they've always been getting.
They're going to like do the IV ketamine thing for 4 months and then run out of money.
Right.
I'm being unfiltered. But I'm like, they do something. So I'm like, find a psychiatrist that's like, my eval is 3 hours. I'm like, that's your psychiatrist. Because they want to know what it was like when your mom was pregnant with you, and they want to know if you're colicky or not, and they want to know when you crawled, and you're like, I don't know that. And they're like, oh my gosh, it makes so much difference in how your brain developed. So to me, I'm going to brag on them in a way they won't.
Does like 60 to 90 minute evals. It's not a 3 hour eval.
Okay, so. An hour and a half. An hour.
Although I will say some of my consults, some of my
in.
consults go that long.
When she said NSTMS, she was talking about the title of the clinic, a Neuroscience and TMS Treatment Center.
That's like such a little, they need their own song.
You want to give them theme music? What are you talking about?
I don't know, something.
Like whenever you say
think wherever you are in the world, you need somebody who's going to be like, tell me your whole story.
Yeah.
Right.
And then you come back and a month later, you're like, Lexapro didn't work. And they're like, oh my gosh, no worries. We got like 7 other options.
Right.
I feel like there are a lot of, that's not very common in psychiatry, sadly.
It is sad. Yep, that is sad.
So that's what they do different. I'll answer it for them.
I wish I wish all psychiatrists started like oncologists start, right? Oncologists see somebody, okay, you got diagnosed with this cancer, and we have these options in front of us. And this has this statistic to get you better. This is this, this is that. And we don't do that in psychiatry. I realized when I started offering TMS, I didn't tell people how likely an antidepressant could work.
Like the statistics behind it.
I didn't say, okay, this med, if you do it by itself, it's only got about a 33% chance to get you better, the first med. If you do it with psychotherapy, we got about a 60-something% chance to get you well. I mean, really well, keep you well. And I think I would have had a lot more people going to psychotherapy early on if I would have been taught that. I wasn't taught that in residency to like say, these are your option, this is the outcome. With TMS, I tell people that. I talk about what's the outcome to get you better, what's the outcome to get you like to stay well at a year. But I never was taught to do that. And that's, I was trained 25 years ago. So I doubt very many therapists are taught to say, hey, when you do this kind of therapy, this is your outcome. When you do this kind, it's this outcome.
I don't think
Right, because nobody like talks about that like that. We all just say, okay, let's try it. Dr. Becker talked earlier, like, I hate to see people who've been in psychotherapy for like 6 months and aren't any better and didn't get referred to go take a med or do something. And I know early on you had a question when we were kind of prepping for this about whether or not people should take meds or.
Yeah, I was going to, that's so funny. I was going to say, I'm like, we've deep dived into this one area and like every other guest, I'm like, shoot, we need to have them like 4 more times.
Yeah, exactly.
But I feel like I see a lot of people in my practice who feel really, really hopeless. Or they like can't get in their car and turn on the engine without a genuine like diagnosable panic attack, right? And I'm like, hey, I am here with you. I'm in this moment with you. We are going to make 0 progress unless you go see somebody for your med management because you are outside of your window of tolerance where therapy is going to help.
Okay.
And they're like, oh, but meds are toxic. And I feel really, I don't know what to do because I so hear that. I'm actually pretty middle ground with that stuff, more so than maybe people think.
Yeah.
But it's like, what do you do with that? Because there's so much culture out there, and I've read so much about that makes you really scared.
Yeah, I mean, it's a challenge we certainly face in the field, because
red dye.
Yeah,
A lot about red dye.
right. Yeah, I mean, unfortunately, psychiatry is, has more of a stigma with it than taking a medication for your blood pressure or what have you. But
or pneumonia or a respiratory infection.
Right.
Sinusitis,
Yeah.
right?
But if you think about it, and Dr. Cochran did a great job earlier of explaining kind of the neuroanatomy of depression and some of the physiological changes that you see. And that's what medications work on, right? They're working on the pathophysiology of the depression, just like when you take a blood pressure medicine and it, works through, your circulatory system to lower your blood pressure. It's really the same thing. It's just, kind of being able to recognize depression for what it is, which is a physical illness, and, I think when you put it in that context, the understanding or the acceptance of medications is easier. But it's certainly true that, I see patients who are like, I don't want to be on medicines forever. But like you said, it's like, well, you're at a point right now where we can't get anywhere in therapy. You're just too sick. Okay, so medications can help kind of get you better enough that you do the therapy that maintains you. You come off the meds in 6 months, and you get
Totally.
I mean, that's a win,
it does
right? And that's
happen.
really the ultimate goal.
Yeah. And I think this is such a difference between kind of the type of psychiatry that you get. Because I think if you're sitting with somebody who's explaining the brain anatomy to you and explaining what's actually happening in your body, that med doesn't feel as scary. But if somebody's just saying, like, you're sleeping too long here, it's really hard to trust that.
Mm-hmm.
Especially when there's so much culturally that can get really confusing. And so I just think I have learned from psychiatrists that I work with, like, there's real value and balance as far as not overprescribing, but also like really seeing what's going on in you and meeting that need. And I think I don't know enough about neuroscience. I haven't gone to medical school like they have, but I feel like what I have seen is there's a lot of progression that's been made in these medications that is not bad to take long term. And so that fear that we have really might not be that valid in some ways.
Well, and Dr. Becker, your initials after your fancy name is D.O.
Correct.
And so that speaks, does it not, to what other options are you besides medicine, or how can you supplement that? Is that right? What is that degree of study about specifically?
What does it indicate? Is it so?
His last name's Becker. I'm confused. How's it Theo?
Hang tight.
Okay.
No,
Hang tight.
so those are my professional credentials. Be a doctor of osteopathic medicine, which
Okay.
There's two main routes you can go to be a licensed physician. There's the more common doctor of medicine, MD. But there's also the doctor of osteopathic medicine, which I could get into the really interesting.
Which they don't call MOD,
Right,
which they
right,
should,
right.
I'm confused. Okay.
And I could get into all the history of that. It's really interesting and goes back to the Civil War and all kinds of stuff.
Huh.
But
Oh my gosh.
as part of our training, we get, I think it's either 200 or 500 hours or something of called the osteopathic manual medicine, which is a focus on using the body to restore itself. And so if you have, for example, if you have a pneumonia, you get restrictions in the movement of your rib cages. And so that can actually exacerbate the illness because you're not taking in air as efficiently. And so you restore the normal functioning and movement of the rib cage to help. It won't cure the pneumonia. You need antibiotics to ultimately do that, but it can help the healing process.
And frankly, as an MD, I wish I was a DO. I really do. So
Just because your style of medicine?
Because what I've learned over the years, everything I didn't learn in medical school was taught in DO training. And so I was like, why wasn't I taught the whole picture, everything that was there? And it's just different programs teach different things.
So you're saying if there's a bunch of doctors, psychiatrists on the beach, the DOs are like the big strong guys kind of kicking sand in the face of the other like MD doctors.
Well, what I'm saying is if you're a medical student, you're looking at programs, and you're really like, if you happen to be listening to this podcast, I'd really consider a DO program over an MD program. And I think MD programs have gotten better over the years. I think they've added supplements. They've learned how to do more physical aspects. They've taught, in psychiatry, they've taught breathing exercises that I didn't learn until like literally 10 years ago. But they've added those things. But I mean, I would highly encourage somebody who's early on looking at a DO program. And frankly, they all should be doing the same thing.
Yeah.
So,
MD programs and DO programs should be doing the same thing.
Same thing.
Yeah, if you're going to be a good doctor, you might as well learn good doctor practice.
Right.
Yeah, figure there's. Oh, you want to be a good doctor? Oh, go to that school. Oh, yeah.
She's not like on the Association of National MDs or anything.
No, I am not. No.
She gets voted to be class president whenever she joins an association.
Well,
all right.
Thank you so much.
Well, we actually accomplished probably about 20% of what we had on the list to do, so we could do many more. So y'all comment if you want to know more or have more questions, and we'll kind of get that to you. But kind of closing thoughts, we had originally thought about just kind of looking at the future of a clinical psychiatric office, and we got a glimpse of it if we're talking about the neuromodulation and TMS and esketamine and maybe some of these other psychedelics.
They're coming.
Yeah,
you think they are coming?
Oh, they're coming.
I think within a year. Yeah,
we'll have. I think one certainly within the next year or two.
Do you think I think NDMA will be out first.
So Google that, Chuck.
Well, my joke, and I got to be careful because I don't want to dishonor the hard work that people are putting into it, but it's very, very interesting to see the switch of conservative, what would be perceived as a conservative healthcare situation to now as ketamine,
right.
And maybe mushrooms or.
But there's a balance in it.
Yeah. But my vision after in my weird mind, I just had this technician opening up the beads, welcome in, come on in.
And with that, we're going to wrap up.
It won't be like that.
I have one interesting point that just, if you think about it, the 1970s and the movement, really the anti-psychiatry movement that began in the 1970s.
That anti-psychiatry movement began in the 1970s?
It began in the 1970s, really has set back patient care 50 years because ECT was being perfected at that time. Well, I shouldn't say perfect. It was being improved upon in terms of the side effects, especially the cognitive side effects. They were using LSD, different psilocybin. They were using these things to begin to experiment to treat mental illness. Then you had the sweeping anti-psychiatry movement come along, and all this stuff got kind of shoved under the rug for 50 years, and we're just now getting back to it.
So this had been thought of years ago.
You had an anti-drug campaign through a presidential party, Ronald Reagan. Basically, was like completely anti-drug. So all the money that would have funded research back then was completely pulled. So we don't have the data that we would have with the psychedelics or with marijuana because it just was completely pulled. So
that's frustrating.
And so interesting. Okay, we got to stop. I'm going to talk for another 3 hours. I got to pee, to be honest. Like really bad.
We are out. Thank you guys for coming. Appreciate it.
Thanks.
We invite you to become part of our growing Healing Centers community. Follow us on Facebook, Instagram, and subscribe to our podcasts on Apple Podcasts or wherever you like to listen to your podcasts. Visit us at healingcenters.co for the most current social links and information. Share comments and feedback on our website. Let us know what topics interest you and what guests you want us to invite on the show. If you are in the healing business as a therapist, doctor, or other wellness expert, please let us know who you are and your specialty. We'd love to be able to connect our listeners to great professionals like you. www.healingcenters.co. Follow us, join us, and grow with us.